So over the next hour, I'm going to talk on the tiny toxins, big threats, recognizing and managing pediatric poisoning emergencies. So I'm going to discuss some interesting cases which are relevant to pediatric toxicology in this lecture, and then through those cases, I hope to discuss some of the important aspects of management of poisoning in children. So if you look at the global epidemiology, what is more commonly seen in children is the accidental poisonings as compared to deliberate or more suicidal poisonings in the adult age. And according to the WHO statistics, there have been over 45,000 deaths in the year 28, according to the report of the WHO injury prevention. And even now, today, pediatric poisoning exposures continue to be a significant cause of morbidity and mortality, not only in the world but also similarly it applies to our country, making this topic an important topic for discussion. Why children are more susceptible for poisonings? In the pediatric age group, we see two peaks of poisonings. As you all know, it's not very common, but however you see, they are seen in two age groups more commonly. One is the toddler age, that is 1 to 3 years, where the children have developed the ability to explore the world, they have developed hand skills, they have developed the ability to experiment or explore various things, and they have the habit of putting everything in their mouth. However, still they lack the sense of danger. So because of that, this toddler age group is considered one of the high risk age groups to have accidental poisonings. On the other hand, the adolescents or the teenagers, you see another peak due to their desire to experiment with recreational drugs or illicit substances, as well as this is kind of a very age where you take a lot of risks, being teenagers, by the influence of the peer pressure or due to various other factors, maybe relationship issues, maybe stress of education, exams. So they have, they are more prone to take poisons deliberately. So during these two age groups, children are at a higher risk of taking poisons compared to other age groups. And there are a lot of things. Paracelsus is one of the scientists once told, everything is poisonous. It's the dose that that determine the outcome, right? So everything can be poisonous, like if you take in higher amounts, right? But there are certain poisons can be fatal in children if you take the normal adult dose, like if it's ingested by an infant. So what are these agents? For example, tricyclic antidepressants that is used for treating depression. So if an infant ingests a single tablet, it can be fatal. So it's very important that you store these medications out of reach to children, especially toddlers, because if they ingest them accidentally, it can lead to disastrous consequences. So not only tricyclic antidepressants, other agents like beta blockers, calcium channel antagonists, opioids, antiarrhythmics, theophylline. So most of these drugs are cardiotoxic, and some of them can depress the level of consciousness, some of them can be respiratory toxic, and this can result in death of the child even with the ingestion of a normal dose that is not considered normal for an adult. And apart from medicinal agents, pesticides, especially organophosphate, some of the pesticides were removed from the Sri Lankan market because of their highly hazardous nature, but still organophosphate pesticides are being used, so it can be fatal if ingestion happens in a young child, even the small amount. As well as oleander, we see a lot of oleander poisonings in adults in the north and east, as well as the north central regions of the country. Still we see it. So oleander can be highly toxic and fatal if ingested by a child. So important thing in assessing any child, similar to adult, any child coming with a potential ingestion is to perform a thorough risk assessment. Because the parents are often worried, anxious, sometimes they don't know what the child has ingested, unlike in an adult where they present with a clear history of ingestion, because most children ingest them accidentally without knowing the hazardous nature. So sometimes there is no clear history available. So it's very important that you perform a risk assessment accurately before you make the management decisions. So this risk assessment refers to a distinct cognitive process through which the clinicians attempt to predict the likely clinical course and potential complications for the individual patient. There are five important things in the risk assessment. First of all, we need to determine what the agent or the agents the child is likely to have ingested. And then it's important to determine the dose, because sometimes the doses are not toxic, sometimes the doses can be toxic or fatal. So it's very important to assess what's the agent as well as what's the amount. And then to make management decisions, especially giving decontamination, it's important to decide or determine the time of ingestion, because there's a window of opportunity where you can use decontamination with certain toxic ingestions if the child presents to the hospital early, before the toxin gets absorbed from the GI tract. And the current clinical status, it's to checking heart rate, respiratory rate, level of consciousness, temperatures, and then toxidromic features. Especially these are applicable to toxidromic agents like benzodiazepines, and patient factors, obese, whether the child is obese, emaciated, whether the child has concurrent liver or renal impairment. These all matter in the management, as well as what the effects of the drug is going to be on the child's body, because some of the toxins are cleared by kidney or the liver. So if the child is having impaired liver or kidney functions, they can accumulate in unusually high levels compared to a child with normal liver or renal functions. And decontamination, decontamination can be used in certain instances where the child ingests a toxic agent which can be absorbed to activated charcoal. So these usually activated charcoal is given to the GI tract, so that effectively controls enterohepatic and enteroenteral circulation of the poison. The usual dose in a child is 1 gram per kilo, and compared to adults, you can try mixing activated charcoal, because it's bad taste. You can try mixing with the flavor or yogurt. That will increase the acceptance rate and compliance in the child. However, before administering activated charcoal, it's important that you protect the airway, especially in drowsy children. Otherwise, the charcoal can be aspirated, leading to an aspiration pneumonitis. And sometimes decontamination is very helpful, and you can give multiple dose activated charcoal, especially when you ingest agents that delay the GI transit time, as well as they remain in the GI tract for a long time. So that's a high chance that you can absorb them and then remove it. So these agents like aspirin or salicylates, barbiturates, theophylline, multiple dose activated charcoal is indicated. However, it's also important to know that certain poisons like iron and alcohol, liquid hydrocarbons, the activated charcoal is not indicated, and sometimes they are contraindicated. And activated charcoal is also contraindicated in the presence of bowel obstruction, GI hemorrhages, and unprotected airway. And not only you can use decontamination, but also you can do elimination, poison elimination techniques. So elimination is used when the poison is absorbed from the GI tract into the circulation. So it's you try to it's action that you take to remove the poison from the circulation, so elimination. For elimination purpose, you can use multiple dose activated charcoal, where the drug keeps on recirculating enteroenteral, low enterohepatic. So there'll be secretion of the poison again back to the GI tract. So in such instances, you can use multiple dose activated charcoal. And urine alkalization. Certain drugs are excreted in urine, and especially they are excreted in high amounts when you make the urine alkaline. So example poisons include salicylates and phenobarbital. So salicylates is still a common agent to be to be seen as a poison among children here in Sri Lanka. And other agents like iron, lithium, where you cannot use activated charcoal, you can try gastric lavage or whole bowel irrigation with clean prep. They are not absorbed to activated charcoal, but they can be washed away from the GI tract using gastric lavage or use of whole bowel irrigation. And after the drug is absorbed, for example, salicylate, methanol, ethylene glycol, lithium, they are dialysable substances. They have a low molecular weight. They are not protein bound, and so they therefore dialysable. So you can use hemodialysis as well in highly toxic situations, highly severe poisonings. You can use dialysis to eliminate the poison from the body. And other occasionally used or available techniques include hemoperfusion, that is by using a cartridge containing activated charcoal. You can use the charcoal as to absorb the drug that is absorbed to the circulation. So you can through hemoperfusion take the drug back into the activated charcoal by hemoperfusion. Examples: carbamazepine, barbiturates, theophylline. And hemofiltration, you can use hemofiltration for medium weight molecules, iron and theophylline. However, in most children, when a child presents with a suspected or potential ingestion, most of these children are may not be symptomatic, or most of the children are likely to have not ingested a toxic dose. If so, then you need to observe these children for a period of time. Especially if they are symptomatic, if they present with vomiting, it's important that you admit such children for a period of observation that can be up to 24 hours if they remain well. And if indicated, you can use simple investigations like blood sugar, cardiac ECG, and then if the observations remain normal and the child remains well, then you can consider discharging such children after 24 hours. Right, so we will start with the case presentations. So I would first present case 1. A 4-year-old boy presented with nausea, abdominal pain, fatigue after 3 days of frequent paracetamol syrup administration for fever by the grandmother, amounting to approximately 120 milligram per kilo per day, exceeding the recommended dose. So this is a real scenario, and it is possible at all the times, because sometimes the parents are not at home and medications are given by the grandmother, and these are possibilities that can happen in a house, right? So grandmother can determine the paracetamol dose erroneously and then can mistakenly give a higher dose of paracetamol. So 120 milligram per kilo per day. So if you have, this is a case of repeated supratherapeutic ingestion of paracetamol, and if the repeated supratherapeutic paracetamol ingestion happens over a period of 48 hours or more, we consider a dose of more than 100 milligram per kilo per day as potentially toxic. And after admission, the investigations are done. It shows mildly elevated liver enzymes, ALT of 110 and AST of 130, and a prolonged INR of 1.5, consistent with mild hepatic injury or early hepatic injury following supratherapeutic paracetamol ingestion. Paracetamol is normally, in normal doses, it's conjugated to, after absorption, and in the circulation, it's conjugated to water-soluble metabolites by the liver, which are then excreted by the kidneys. However, in overdose, it's not the conjugation process. The metabolic route becomes the P450 enzyme pathway, and this results in formation of N-acetyl P-benzoquinoamine or NAPQI. And NAPQI is under physiological conditions is converted to non-toxic metabolite by glutathione. However, when you ingest a very high dose of paracetamol, this glutathione gets depleted, and there will be no more conversion to non-toxic metabolites, and then NAPQI remains in the circulation, and NAPQI is highly hepatotoxic, and it damages the cellular structures through oxidative stress, leading to hepatic cell death. So it can result in acute liver failure. And there are differences in management of pediatric against adult paracetamol poisoning, right? So in the presence of a paracetamol level, now, in our country, governmental hospitals, we don't have a paracetamol level, right? So first I would discuss what to do if you have a paracetamol level, and then next I would discuss what to do when you don't have a paracetamol level. If you have a paracetamol level, then you have to determine the presentation. If it's a single ingestion, single toxic ingestion, syrup, most of the time the children ingest syrup. So syrup, you have to give activated charcoal within 2 hours of ingestion, whereas if you drink tablets, the window is 4 hours. 4 hours after the ingested time. However, now this is a case of repeated supratherapeutic ingestion, so it's hard to it's not of very much use because it has happened over a couple of days. So if the child presents with less than 2 hours, you have to give activated charcoal. However, if there's a late presentation, if you have facilities, then check paracetamol level, and we must perform ALT on admission. And if the presentation is after 8 or 24 hours or more than 24 hours, they are not good markers of the toxic ingestion. So you have to go by the dose. So if the dose is over 100 milligram per kilo per day, and if your liver functions are high, then it's recommended that you commence acetylcysteine, N-acetylcysteine infusion. And then when you get the results, then see whether the ALT is less than 50, and the paracetamol level is over the nomogram. Or now again, supratherapeutic injections, you can't go by the nomogram, so you have to determine the concentration. So if the paracetamol levels are above the nomogram or the ALT is more than 50, then you have to continue N-acetylcysteine infusions. However, in the absence of both of them being negative, then you can stop N-acetylcysteine infusion. And sometimes children, single ingestions, sometimes they can present with very high toxic ingestions, and then there's a difference in management. If you have the nomogram, and if you can see it, and if the level is twice above the upper limit for treatment threshold, your second bag should be 200, like double the dose. Anyway, your first bag is 200 milligram per kilo, and the second one is 100 per kilo. But if you have a high ingestion, then your second bag is also 200 milligram per kilo, and they are administered as 2-bag regimes. The first one over 4 hours, and the second one over 16 hours duration. And before, now whatever ingestion, the last box I'm referring to, 2 hours before the completion of the N-acetylcysteine, we have to check the ALT level, and if facilities are available, paracetamol level. And if the ALT is still above 50, or if it is still rising, or if the paracetamol concentration is over 10 milligram per liter, then continuation of N-acetylcysteine is indicated as far as your ALT is above 50 units per liter. And in our setup where we don't have paracetamol levels, we have brought down the toxic dose. So what we consider as toxic is over 150 milligram per kilo, and then see whether the child is asymptomatic or symptomatic. So if the child is ingested less than 150 and child remains asymptomatic, then there is no treatment indicated on admission. However, we have to do the baseline investigations, ALT and INR, and if the ALT is above 50, then we have to continue the standard NAC 2-bag regime infusion. And then before, like couple of hours before the infusion is over, we have to repeat the INR and ALT. And if the ALT is less than 50 and the INR is normal, then we can consider stopping N-acetylcysteine infusion. However, if the ALT is above 50 and INR is above 1.3, then it's indicated to continue with N-acetylcysteine for another 24 hours and then recheck the ALT and INR levels again 24 hours after the commencement of the 3rd bag. And activated charcoal in a single toxic ingestions can be administered if the child presents within 4 hours of ingestion, that is for tablets, and up to 2 hours you can administer in case of suspensions or the syrup formulation of paracetamol. The effect of activated charcoal lessens or disappears with the delayed presentations. And case number 2, a 2-year-old boy presented with fever for 2 days and his urine on presentation was dark. And at admission, the parents were worried about dengue fever. Now this child presented about 3 years ago, so during a dengue outbreak, and parents were worried that whether the child has dengue fever, presenting with dark urine and fever for 2 days. However, physical examination found marked pallor and a tinge of icterus, leading to doubt as to whether this could be dengue or something else. And then observations were done on admission, and the heart rate was 184. There was marked tachycardia, and respiratory rate was 42. There's tachypnea, tachycardia, as well as, surprisingly, the saturation was 76%. So it's quite low. And child underwent further investigations to identify the etiology, and the full blood count showed a hemoglobin of 3.5. And we suspected the possibility of hemolysis because there was acute onset pallor and icterus, and the reticulocyte count came as 15.2%, which was very high. And we also did LDH, marker of hemolysis, which came as 1263. And we also did the bilirubin. It showed indirect hyperbilirubinemia, again supporting hemolysis. And we did the blood picture, which shows microspherocytes and polychromatic cells. Many bite cells, normoblasts were also seen. And apart from the mild neutrophilic leukocytosis, rest of the blood picture was normal. And an ECG was also performed due to low oxygen saturation and tachycardia, and ECG showed ST depressions, so that is suggestive of toxic myocardial injury. And given the acute onset, the clinical presentation and the dramatic clinical presentation and lack of a clear system involvement, we suspected a potential toxic ingestion. And then we specifically inquired about the what happened over the preceding 2-3 days. And then mother admitted that the child had been playing with mothballs about 36 hours earlier, and the mother noted that the 2 mothballs had been missing. And this major degrees of hemolysis can lead to fever. So can be can mimic sometimes a viral fever, but acute onset severe hemolysis sometimes can give rise to fever. So this whole presentation was the presentation following the mothball ingestion, and one of the well-known effects of mothball is the methemoglobinemia. So we determined the methemoglobin level, which came as 9.7%. So that confirms severe hemolysis and methemoglobinemia following an ingestion of 2 mothballs in this child. and we had to treat the acute hemolysis. So child receives, after initial hemodynamic stability, the child received 40 ml per kilo of blood transfusions, as well as high flow oxygen therapy for low saturation methemoglobinemia, and we also suspected G6PD deficiency, because naphthalene that is contained in mothballs can lead to severe hemolysis in children with G6PD, and the G6PD assay also confirmed, which was done 3 months after the initial presentation, once the hemolysis has settled, which confirmed the G6PD deficiency. So this child presented with acute onset hemolysis and methemoglobinemia following ingestion of 2 mothballs, and the underlying diagnosis was the G6PD deficiency. And let's move on to case number 3. Here a 2-year-old girl presented to the local hospital following acute onset difficulty in breathing, and she vomited several times over the last hour. So which is suspicious for a toxic ingestion. When someone presents with vomiting, it can be food poisoning, but at the same time, if it's not food poisoning, you have to suspect other causes, whether there can be toxicity, whether it can be metabolic. So you have to think. And then the family history revealed the mother was on steroid inhalers for bronchial asthma, grandmother was on paracetamol and wintergreen oil for chronic back pain. And observations revealed a temperature of 38.1 Celsius and a respiratory rate of 42 and a heart rate of 102. So there was tachypnea, tachycardia, and there was temperature, like mildly raised temperatures. And child also had excessive crying on presentation with some sweating, and the blood gases revealed more towards respiratory alkalosis with a low PCO2 and a pH of 7.45 and a normal lactate. So they were all like this constellation of clinical signs and symptoms: mild hypothermia, tachypnea, tachycardia, excessive crying, and mild respiratory alkalosis with acute presentation, all led us to suspect the possibility of ingestion of wintergreen oil, which contains high amounts of methyl salicylate. Salicylate, the toxic in toxicity, it uncouples the oxidative phosphorylation and it inhibits the Krebs cycle. So when the Krebs cycle is inhibited, that leads to activation of the anaerobic respiration, anaerobic metabolism, resulting in accumulation of lactate. So lactate with higher grades of toxicity lead to metabolic acidosis. But at the initial phase, a child can present with vomiting, tachypnea, that is due to hyperventilation, and respiratory alkalosis before the subsequent metabolic acidosis sets in. So it stimulates the respiratory center as a direct effect, leading to hyperventilation and respiratory alkalosis. And also salicylates can delay the stomach emptying, absorption can be prolonged, and volume of distribution is increased in the presence of a significant overdose. And so this child was managed down the standard lines. So in salicylate toxicity, because it's absorbable, you can give both, and also it remains for a long time in the GI tract in overdose because of the delayed gastric emptying as well as lowered bowel movements. You can do gastric lavage up to 4 hours in a significant overdose, not just 1 hour. And also you can give multiple dose activated charcoal somebody who has ingested a sustained release preparation or significant overdose, because it delays the gastric movements and slows down the bowel motility. The drug remains for a long time within the GI tract, so that it can be absorbable with activated charcoal. If in our hospitals we don't have salicylate levels, but in the developed countries they do paracetamol and salicylate for most toxic ingestions as part of their routine investigations. So if you are doing salicylate measurements, one measurement is not enough. You need to perform repeated salicylate levels, because a single level can be misleading and it's change over time. And if the patient develops a conversion after ingestion of a salicylate acid, salicylate, you must give dextrose even if your blood sugar is normal, because although your blood sugar is normal, it can lead to hypoglycemia. The CNS, central nervous system blood sugar levels can be very low despite the blood sugar is normal. So any child present with a seizure and a salicylate ingestion, we have to give IV dextrose. And the mainstay of treatment is after your decontamination is a urine alkalization, because salicylate is excreted through the kidney, and it's excreted more with alkaline conditions. What we do is, by administering IV sodium bicarbonate, we try to make the urine more alkaline. We try to keep a urine pH of over 7.5 and a urine output of over 3 ml per kilo per hour. So with that, with alkaline conditions, with more urine output, we try to flush out excess salicylate through the renal route. So hydration as well as IV sodium bicarbonate are the treatment. However, if the child present with a significant salicylate ingestion, you have to consider giving starting hemodialysis. That is, when you have convulsions, you remain symptomatic, you're drowsy, and severe metabolic acidosis, then urine alkalization may not be just enough. And this is one of the dialysable substances, salicylate. For us to do hemodialysis, the poison should be dialysable. So salicylate has all the characteristics that are that makes it a dialysable substance. It has a low molecular weight. It's not bound to proteins. It has a lower volume of distribution. So with all that, hemodialysis is effective in patients who are presenting with organ injury or refractory intoxication following severe toxic ingestions. And let's move on to case number 4. A 4-year-old child presented following a generalized tonic-clonic seizure lasting for 10 minutes. So this child presented about 2 hours ago at a ward, and who was a previously healthy child with no family history or past history of convulsions and not on any medications. And when a child presents with afebrile convulsion, it's the usual practice to do the blood investigations, including blood sugar, calcium, magnesium, electrolytes, and to check about the meal times. So this child had the last meal prior to about 6 hours prior to the convulsion, and it consists of a salad that is made of Coaca leaves, which is known as Coccinia grandis, as shown in this image, which she had not consumed before. And Coaca leaves are consumed by Sri Lankans, especially in villages when they have type 2 diabetes, because of the presumed benefit in controlling the blood sugar levels. So it was actually consumed by the grandfather. However, this child also had eaten it, the salad, before the presentation, and there was no other history suggestive of an alternative diagnosis for hypoglycemia. And we did a critical blood sample to look for the reason for hypoglycemia, and all the blood investigations, including organic acid profiles and blood gases and the other investigations, they were normal, and the ketone bodies were negative. So only abnormality was the low blood sugar, which was treated with supportive care. This is not very much reported in literature. Coaca, or the Coccinia grandis, is known to increase the glucose tolerance in those who are having type 2 diabetes. It reduces the glucose absorption from the gut. It increased insulin production from the pancreas, and it reduces the release of glucose from liver and increased glucose uptake by fat and muscles cells. So all of these will result in drop in the blood sugar levels, and there were no previous reported incidents. However, reported means, but there were previous, but not reported. And especially these leaves are consumed mainly in our country, and there was not much evidence as to why this child had developed the conversion, but child clearly presented with a hypoglycemic conversion after ingestion of these leaves, and we have ruled out the alternative causes for hypoglycemia by doing a critical blood sampling. So it can be possible. So the message from this case is that it's possible that a child, unlike to an adult, because of their smaller body mass and the altered pathophysiological mechanisms, potentially can lead to a lower blood sugar levels that is low enough to present with symptoms such as conversion. And the management, this child was managed with supportive care with IV dextrose, and the child did not need any other management, and child recovered. And then child was advised not to consume the same salad or similar salads in future. And case number 5, this was a 12-year-old boy who presented following a deliberate poisoning of a laundry detergent. So actually, it was not the child who ingested, but the child ingested this poison with the influence of his father, who had given this to the child, as well as the father himself had this poison for him, like by himself. And both child and father had attempted to commit suicide by ingestion of this laundry powder, which was later recognized by this as pinso. It consists of 2 sachets, one with brown crystals that contain potassium permanganate, and the other one with white granules that contain calcium oxalate. And this child has ingested 5 oxalic acid powder packs weighing 16 grams that was dissolved in 500 ml as a soft drink. And within 1 hour of ingestion, the child developed vomiting. Not only vomiting, the child had hematemesis as well, with abdominal pain, because calcium oxalate, the oxalate content, it can be highly toxic to the body, and it can result in gastric erosions and hematemesis, as well as it has significantly toxic effects on the kidneys. And this child went into acute kidney injury after the laundry detergent poisoning. The gastric lavage was performed in the local hospital, and after coming to the hospital, because this oxalic acid binds to calcium and it lowers your calcium to very low levels, so hypocalcemia is a risk in such children. So hypocalcemia, as you know, it can lead to cardiac arrhythmias, including long QT syndrome, and also other cardiac arrhythmias. So child can die of cardiac arrhythmias as well as from the acute kidney injury. And oxalic acid is toxic to the kidney. It results in acute nephritis due to oxalate toxicity. So child was monitored for renal functions and then noted to have acute kidney injury. And then down the sandy lines, the child was treated with prednisolone, because what they develop is an interstitial nephritis, and child responded to the prednisolone and then later tapered off over the period of 7 days. And acute kidney injury was managed with IV sodium bicarbonate, that is to correct metabolic acidosis, and the severe hypocalcemia was managed with IV calcium gluconate and calcium carbonate, and child was monitored for cardiac functions. Like a child was kept under continuous cardiac monitoring to look out for cardiac arrhythmias, and then after the child recovered, child was referred to child psychiatrist assessment. The next case number 6, is a 7-year-old male child with special needs, developmental delay, presented following abdominal pain and abnormal behavior for 1 day duration. And most of these children are not able to express themselves very well, and they might express it by some change in their behavior or cry. So it's very difficult to recognize compared to adults. and this behavior was associated with child complaining of some retrosternal chest pain, and child was noted to be having flexion posturing and appeared restless. And he was not able to swallow foods, so giving rise to doubts as to whether something was stuck in the mouth, or something the child has ingested, leading to this clinical presentation. And child underwent X-ray, and then found to have a coin-like substance, which was later found to be a button battery. So button batteries are found in remote controllers, thermometers, watches, calculators, toys, and children with their habit. Now this child is a 7-year-old. It's not the common age, but it's good to remember that children with special needs, developmental delay, irrespective of how old they are, their behavior may be similar to a toddler, and their risk-taking behavior and the ability to judge the risks may not be good enough. So they can accidentally ingest with these substances without knowing the real risks. And button batteries, the management depends on where you see the object. If the button battery is lodged in the esophagus or the upper airway, that can cause serious tissue damage in as little as 2 hours, because it can, if it's break and if it erodes into the esophagus or the trachea, it can lead to tracheoesophageal fistula, or it can break into an artery resulting in hemorrhage. So it can lead to acute complications. Child may present with wheezing, like if such a child can present with wheezing, drooling, coughing, hematemesis or vomiting, chest discomfort, and refusal to eat. In management of a button battery, we have to perform the X-ray neck, chest, abdomen, and then locate where the button battery is. It's not recommended to induce emesis, because it can sometimes dislodge into airway, and the ones that are stuck above the level of the diaphragm, we will have to remove it endoscopically, because if you leave it, it can erode and lead to those fatal complications. However, if it has gone past the stomach, that is reassuring, and you don't need to do much. It's just that you have to monitor the child for the passage of the button battery through stools. Endoscopy is not needed. So it's very important to do the radiography and then locate where the button battery is. And complications, like I said, it can erode into trachea or the esophagus, leading to fistula. It can lead to chemical pneumonitis, abscess formation, aspiration, pneumonia, and tears in large vessels if the button battery erodes into the trachea or the esophagus and then erodes further into a major blood vessel. Case number 7. This was a newborn who was noted to have tachycardia with no respiratory effort at birth. So child literally didn't breathe, but had a heart rate of 130, and child was noted to have poor tone. Child was quite floppy, and the child appeared a bit cyanosed in lips, and the child started the spontaneous breathing following 5 inflation breaths. Perinatal history: the child was born by normal vaginal delivery, and mother had a long stay of 10 hours in the labor room because there was poor progress of labor. So child, after initiating breathing, but the breathing was shallow, the child was taken to SCUBU and then started on CPAP. After 30 minutes, the baby again developed bradyapnea and shallow breathing with the respiratory rate in the range of 12 to 16. That was very low for a newborn, without any signs of respiratory distress. Saturation was low, 85% on room air. However, improved to about 93% by increasing the FiO2 to 60%. Chest X-ray revealed completely normal findings. So this was a child who actually had opioid toxicity. The mother had been given pethidine, and then because of this, and if the baby is delivered within 4 hours, then the newborn is likely to have the toxic effects of those opioids, and the child will have the toxidrome that is known as opioid toxidrome, presenting with bradyapnea and floppiness and low JCS and pinpoint pupils. And this can also be a problem in the teenagers, where where they tend to use or experiment with illicit substances such as heroin, which is a strong opioid. So not only it can affect the newborns, but also it can affect the teenagers who become victims of illicit use of illicit substances. And our country, we don't have data. It doesn't mean that we don't have these children reported. We don't have this number of children. However, we don't have reports, so it's worthwhile studying the real burden of these problems in our country. So from the United States, it showed that nearly 9,000 pediatric deaths were linked to opioids for a period of 17 years ending from 2016, according to their published data. So which is a significant number, 9,000 pediatric deaths that are due to opioids, and most of them were not only the newborns but also the teenagers mostly. And the drugs involved in infant deaths in United States during a 2-year period from 2015 to 2017, where the mother is a drug addict, and mother uses opioids like heroin. So the newborn can be a victim of such instances, and that has resulted in nearly 80 deaths in this time period in the United States, which is quite significant. So that is due to the opioid toxidrome. So management of opioid overdose, the treatment is supportive. So if the child doesn't breathe, you need to start bag and mask ventilation and established breathing. But it is not most of the time you don't need to ventilate these children, because the effects are short lasting. Sometimes they would recover, and you see a rapid response to administration of naloxone, which is the antagonist of opioids. So administration of naloxone is important in such children who are presenting with the opioid toxidrome, and they recover quickly unless hypoxic brain damage has happened. And there are various types of opioids, especially who use illicit substances, and sometimes you may have to commence naloxone infusions when you consume an opioid with a longer half-life. And case number 8, an 8-month-old infant presenting following a generalized convulsion. And according to the mother, the infant had been feeding normally, and there was no history of fever, vomiting, diarrhea, choking, apnea, or cyanosis. So it's not kind of very not much keeping in with the history. And social history revealed that the mother was separated from the child's biological father recently, and the child had currently been living with his stepfather and the maternal grandmother. So that's concern about child safety, and in this background the child presented with a generalized convulsion. And the general protocol for generalized convulsion, non-febrile, afebrile convulsion. So blood sugar on admission revealed 1.3, which is very low. So it's likely a hypoglycemic convulsion. And then it was treated symptomatically, but 1 week later again the child presented with another generalized convulsion and was found to be having hypoglycemic with a blood sugar this time on 2.1 millimoles per liter. And then at this point the child underwent critical blood sampling for hypoglycemia, and child remained drowsy for nearly 6 hours. And investigations were coming normal, like septic screen, urine toxicology, CT brain, didn't reveal any intracranial pathology or infection. Urine ketone bodies were negative, so it's a non-ketotic hypoglycemia. Ammonia, lactates were normal, and blood sugars were persistently low. The child was treated with 12.5 dextrose, and critical blood sampling revealed a high plasma insulin. And then it can be endogenous or exogenous. So if it's exogenous insulin, then your C-peptide should be normal, but in this child C-peptide came as high, which is suggesting a toxin other than insulin administration and CT abdomen was normal. Anti-insulin, insulin receptor antibodies were normal. So these were done to rule out any insulin-producing tumors, and full metabolic screen, glucose tolerance test, and prolonged fasting did not reveal any abnormal findings. So this child actually had been given sulfonyl, like it's a toxic ingestion, which this syndrome we recognize as Munchausen syndrome by proxy. It can happen in families with safety concerns. So this mother had given sulfonylurea drugs to the infant, and the child had started convulsion. So this is one of the drugs where small amount can be fatal in a young child. So child was found to be profoundly hypoglycemic, and even a small ingestion can lead to unregulated insulin release. So the endogenous insulin action will lead to significant hypoglycemia in those who ingest the tablet. And the studies from around the world has revealed that the majority of those children who present with such toxic ingestions present within within about 8 hours of ingestion. And the management is it's important to observe these children with frequent blood sugar monitoring, and first line is administration of IV dextrose, and those who have refractory hypoglycemia, IV octreotide is indicated. But this particular instance, we need to initiate the child protection workup, because this is an induced hypoglycemia rather than an accidental ingestion, because you need to suspect, like in a 8-month-old child or like a 5-month-old, who do not have that exploratory capacity to self ingest something, and then you hear some unfitting history with the circumstances of ingestion, then that is where you have to suspect the possibility of non-accidental injury or non-accidental poisoning. So this is one such instance. And the last case number 9, a 3-year-old child presented with a generalized convulsion, and prior to the convulsion, the child was attending a religious ritual along with his parents, and the child initially had odorous vomiting 3 times, and the parents suspected that the boy had tasted one of the white colored tablets that were burnt on coconuts, that is the camphor, which we usually do to bring peace and prosperity during this religious ritual. So camphor is one of the agents that are commonly used in religious rituals, but also it is highly toxic, and the usual victims are children, not adults. So this child, 3-year-old, with the exploration, the child had accidentally ingested the camphor tablet, and then resulted in camphor toxicity, presenting with a convulsion. So camphor is highly toxic, and it brings on rapid onset toxicity, and not only the camphor tablets, but also in certain other products like Vicks inhalers, camphor containing mothballs, they act as sources of camphor. And sometimes camphor can be contaminated with salicylates, with some products leading to enhanced toxicity of both camphor and salicylate. And the most common manifestations are neurological manifestations, which can include seizures, restlessness, delirium, confusion, and hallucinations. For camphor poisoning, activated charcoal is not recommended. The mainstay of management is the supportive care. That is, if the child becomes, if the child presents with a convulsion, we have to manage the convulsion down the standard lines. There is no antidote or any other specific medication, and observation of such children is very important to prevent further complications. And there are a few less straightforward presentations, especially because these young children are non-verbal, or they don't provide a clear history of ingestion. Identification of toxidrome, based on the presenting symptoms, is very important to decide on the likely differential diagnosis. So these children include those who present with a reduced conscious level without no etiology, and those who present with altered behavior with no obvious cause, or a teenager who has potentially ingested an unidentified substance that is reported to be illicit, like MDMA. So clinical toxidromes, so recognition of clinical toxidromes is very important in this regard, and it is a clinical fingerprint that is characterized by a classic constellation of symptoms and signs due to the toxic effects of the chemicals contained within the substance. And they are more common in old children and teenagers who abuse recreational drugs. However, while recognizing the clinical toxidromes, sometimes other medical causes can be in the differential diagnosis, and we should not miss. For example, if a child presents with unexplained change in behavior or drowsiness, then we must rule out other important medical differential diagnoses such as septicemia, meningoencephalitis, metabolic crisis, intracranial hemorrhage, hypoxia, and hypothermia. And there are a few clinical toxidromes that's worthwhile remembering, right? So one thing is the opioid toxidrome, which we discussed already. They present with the typical triad of signs that are respiratory depression, CNS depression, and the meiosis, right? So if you have this triad, it is very likely the child has ingested an opioid substance, which can include codeine, morphine, or pethidine in case of newborn presenting with the opioid toxidrome, or heroin in a teenager who is living in the street. So it depends on the circumstance. And the importance about knowing this is, how quickly you can respond. Like if you know this is an opioid toxidrome, then you can administer naloxone. If there is a clear presentation of opioid toxidrome, then you can quickly administer naloxone and rapidly reverse the intoxication. And if you have CNS depression, respiratory depression with a variable size pupil with cardiac manifestations, bradycardia or low blood pressure, then we recognize a sedative toxidrome. Examples include diazepam ingestion of alcohol, and again, there the management is supportive care. No antidote is available. And the constellation of symptoms including diaphoresis, lacrimation, urination, diarrhea, bronchuria, vomiting, meiosis, salivation. So all of these are due to the cholinergic crisis. So then you can suspect cholinergic toxidrome. The common agents include organophosphate and carbamates, the pesticides ingestion. So you can quickly initiate treatments including administration of atropine, ventilation, palidroxine, if depending on the facilities available. And then sympathomimetic and anticholinergic toxidromes are the two toxidromes that share common clinical features. They both have activation of the sympathetic. So anticholinergic is the opposite of the sympathetic, so it's very difficult to clinically differentiate. However, the ones that are put in red, that they help in differentiating the two toxidromes. In sympathomimetic toxidrome, you see sweating, whereas on the other hand, in anticholinergic toxidrome, you see a dry red skin. And the bubble sounds are increased in the presence of sympathomimetic toxidrome, whereas bubble sounds are hypoactive in the presence of cholinergic toxidrome. So importance of the differentiation is to narrow down your differential diagnosis. If it's sympathomimetic, the examples include illicit drugs like cocaine, amphetamines, MDMA. But if it's anticholinergic, then you have to suspect plant poisons like datura, atropine, antihistamines, tricyclic antidepressants. And then the supportive management are more or less the same, which include benzodiazepine, supportive care, active cooling for hypothermia. But there are some differences in management. For example, availability of antidotes in the presence of certain poisoning. So identification of toxidrome is helpful in narrowing down the differential diagnosis, and in terms, in such terms, it's helpful in starting the management early. And poisoning and deliberate self-harm. So they are children who display self-harming behavior, deliberate self-harm. They have a significantly high increase or risk of underlying psychiatric illness like depression. So this is a window of opportunity where we can use to refer all such children presenting with deliberate self-harm for a detailed psychiatric assessment, so that it's like the tip of the iceberg. Most of these children, they live in the community but they don't present. So all children who are presenting with deliberate self-harm, they should be referred for detailed child psychiatry evaluation and support, irrespective of how trivial the dose they have ingested. So the key messages that I want to pass on are that although the most childhood ingestions are of low lethality, poisoning in children accounts for significant mortality worldwide, and risk assessment is a crucial step in the management of the acutely poisoned children, and identification of symptoms or toxidrome helps in formulating a right differential diagnosis in those with less straightforward presentations. Thank you.